We're going to start the afternoon talking about gaps in care. And during this session, we'll highlight successful best practices of measurable results with gaps in care integration. We'll discuss the evolution and implication of a national standard, integrating gaps in care into provider workflows, and how to effectively close the gaps in care and improve quality scores. Moderating this panel will be Borgnakke. He's the Emerging Solutions Manager at MyHIN. We have a very large panel here, speaking a lot of representation. We have Tara O'Neill, Director of Quality Improvement with Meridian. Sharon Kurt is Manager of Quality Improvement with HEDIS Operations at Priority Health. Linnell James is the Business Lead with Health Information Exchange and Innovation at Blue Cross Blue Shield Association. Danny Zajac, Medical Data Analyst at Olympia Medical, and Brynn Rhodes, Principal with Dynamic Content Group. Welcome.
Good afternoon. We were a little disappointed we didn't get to use the comfy chairs, but we'll make do. So I'm Borgnakke. I'm the Emerging Solutions Manager at MyHIN, and one of my primary responsibilities is maintaining our quality-related use cases, including Skimmer with the QRDA files, as well as the Physician Payer Quality Collaborative, or PPQC, with HEDIS data. What we will start with, I'll go over a couple of slides to just level set the conversation, and then each panelist will have a few minutes to kind of introduce themselves and give their thoughts on the topic. And then we've got a couple of questions ready to go, and then we'll open it up to questions from the audience finally. So if we can queue up the slides, maybe I can. All right. So we're going to talk today about quality measures and the results of the quality measures. And this is a topic that often gets overlooked as the industry is focused on the actual producing the quality measures and applying them to plans and providers. But what happens when we actually get the results? I mean, what do we do with them? How do we disseminate them? And this is a topic that's often overlooked. So what is a quality measure? Just as a basic level set, grabbed it from cms.gov, this definition here. But essentially, it's a specific tool and a specific metric that you can apply to a provider or a health plan that can help us measure the way we deliver care in general. Just want to point out that there are multiple reporting programs that you all probably deal with on a daily basis. We have HEDIS, which evaluates payers, but they also need that supplemental clinical data. But there's also ECQMs, which is a predefined set of quality measures selected by CMS, which is used in a litany of their programs, including MIPS and others. So gaps in care. I think this is a little bit of a misnomer, because when you say gaps in care, the implication is that it is a non-compliant patient, that it is a patient that has not received the optimal care, and thus someone is being dinged for that on their performance metrics. But really, I want us to think about it as patient-level measure results, right? You don't necessarily just want the non-compliant patients and the gaps. You want also the compliant patients, so you can take better action as a provider, and that opens up a whole lot of population health opportunities as well. But the idea is you close gaps or open discrepancies in care. It results in higher quality score measures, and ultimately what we're doing is achieving the triple aim. So that's improved patient experience, better health outcomes, and reduced costs. So specifically in the HEDIS space for now, the status quo of how we distribute gaps in care results in this kind of spaghetti diagram, as that eventually populates there, where each payer has their own HEDIS engine. They collect whatever supplemental and claims data they have access to, run it through their engine like a Novalon, and it outputs measure results also at the patient level. In order for clinical side providers and POs and hospital systems to see these gaps in care reports, as we call them, Those are hosted in various portal systems, which are, of course, unique to each payer. So you have to get a login, you go into that payer system, and you can view them, download them. Some payers also send those gaps in care reports out proactively, some even with email or fax, anything they can do to get those gaps in care reports or measure results in front of the clinician so they can take action to better their scores before they're ultimately due. So what's not kind of listed even is on the ECQM side, where we have these QRDA files and we have to report annually in the case of MIPS, and we've got CPC Plus and all kinds of other CMS programs that don't really have a feedback cycle. They're calculated by the EHR, and your EHR will show you what your results are on your various ECQM quality measures, but there's no gap in care kind of robust system, and there's no ongoing feedback loop throughout the year. You just kind of press the button, there comes your Cat 3, and you send it in, right? So suffice to say, our measure results dissemination or gaps in care dissemination is not where it needs to be as a nation industry. So here's kind of a statement, and looking for the panelists' reaction to this, but essentially a standard in terms of some way to represent patient-level measure results and gaps in care that we all agree on what the content is and what the format of that message would be a powerful tool and an important step toward building a national ecosystem of gaps in care and measure result dissemination, right? So it's going to make transport easier, aggregating them together, doing population-level health analyses, and ultimately presenting them to the provider and caregivers that have a chance to close the gaps and improve the health that they're trying to measure. So when we think about how to make that standard work, we need to make sure that it's comprehensive but also flexible, because keep in mind that HEDIS measures are not the only measures out there. ECQMs are not the only measures out there, right? There's a whole litany of measures that we need to make sure this would work for and support. Also keep in mind that those different quality measures are calculated by different entities, right? The HEDIS engine at the payer level operates differently than the EHR calculating ECQMs with just the clinical information available. And we need any kind of gaps dissemination to support both of those, be cognizant that multiple entities can calculate these results. And then also think about all the downstream things we can do with those results once they're calculated, and make the format in a way that could help those type of systems use the data better. So this concept of a standard way to represent patient-level measure results is kind of this emerging concept that's come up in a lot of national conversations. So Linnell and I and Brynn and others were at the Digital Quality Summit, which is hosted by NCQA, which owns and operates HEDIS, as well as HL7, a national standards company. And CMS was present as well, and we're all recognizing that there's been so much emphasis on the calculation of these measures and who needs to do them and what the requirements are, and we haven't thought about what do we do with this great result data and how do we use it to improve health. So that's being recognized at a national level finally now. Linnell will tell you more about Vinci, which is an operation dedicated to advancing FHIR and value-based care. And others in the country, Diameter Health has partnered with HSX to pilot successfully a way to disseminate measure results as well. So I think without further ado, we can pause the slides there, and right now we'll go through each panelist, give them 3 or 4 minutes, and we'll just go down the line here. Tell us who you are and what your organization represents, and kind of from your perspective, what are your thoughts on gaps in care, measure results, what are your pain points and ideas for the future? And then we'll dive into some specific questions. So we'll start with Danny.
Hello, my name is Danny Zajac. I'm from Olympia Medical, a physician organization based out of Livonia, Michigan. Before I get started, I do want to thank everyone at MyHIN for all the efforts put forth to coordinating this event. I want to thank my coworkers here as well. I want to start off with, I'm very excited with all the challenges that everyone has presented with us that we have to face and address. But I think as a physician organization representative, we have a responsibility, and we share that responsibility with everyone else in the room. And we have to be not only cognizant, but sympathetic to the realities of the barriers and the limitations that independent physicians face on a day-to-day basis. We can talk and plan for the future, but there's some realities that we have to address first. With that being said, I am fully supportive of continuous improvement. I believe in the initiative to learn, unlearn, and relearn and adapt. However, with this gaps in care, the importance of this gaps in care initiative is to simplify things, okay? We have to change the status quo, we have to think differently, and we have to create simple and user-friendly designs. We continuously hear individuals being intimidated by technology, and that's what's preventing us from taking advantage of the great things that are at our fingertips. So as long as we can find a collective way to organize and standardize across the continuum, I think we'll be successful. Thank you.
Hi, my name's Tara O'Neill, and I'm the Director of Quality Improvement at Meridian Health Plan here in Michigan. I am one of those folks who are intimidated by technology, so I'm glad to be sitting next to you. Thank you again for having me. I'm very excited to talk with all of you. I think I could represent a unique perspective on the payer side and maybe paint a small picture of the challenges as we see them. So as you know, gaps in care are extremely important for quality improvement, not only because they're evidence-based and move toward improving the triple aim, but also, I mean, they hit us in the pockets, right? From a health plan perspective, we are impacted for accreditation, NCQA, CMS, NQF. There are multiple measures and withhold programs that all impact us financially. So not only do we have this huge responsibility to make sure that we are taking care of the members that we're privileged to serve, but also these are our company and our strategic goals all aligned around those same gaps in care. So for us, I hope that sets the stage on why it's important. So some of the barriers that we face, again, when I'm talking about all these different entities and how it impacts us, we have really tight timeframes, and these measure sets are changing constantly. So even since we started work with PPQC, we've probably added 60 new measures that are now a focus for us, or a gap in care that is now a focus. So for us, keeping up and trying to make sure that we are prioritizing appropriately is definitely a pain for us. I would say that pain is compounded by the fact that there are all these other health plans and other provider groups who are doing the same thing. So our priorities don't always align either. So I would say that's one of the biggest challenges that we are up against.
My name's Linnell James, Blue Cross Blue Shield Association. I was one of the founding members working with folks from United, working with folks from Cigna in starting the Da Vinci project that looked at FHIR and focused on value-based care. One of the things that, as we've focused on Da Vinci, we've looked at use cases. Standards is something I've been involved in my entire 15-year career at the association, National Electronic Standards Unit, now called the Health IT Unit. But one of the things that came about as we looked at forming Da Vinci a year ago was what use cases are we going to focus on? And the choice was made to focus on value-based care. And an interesting thing happened as we looked at the first 9 use cases. The use case that was the first one that we worked on was a quality measure use case. Just to give you a sense of even across all the major payers in the country, all the major EHR vendors, there was consensus. And in fact, it was an interesting use case that I didn't really think was that important. 30-day med reconciliation. How do you close that? Well, how hard can that be? Turns out it's really very hard, because when did the patient get discharged? When does the 30-day start ticking? How do I consistently know when it's closed? I called my friend at Cerner and said, how do you do this 30-day med rec? And they said, let me get back to you. That's not what usually happens when I call somebody from the association asking what I thought was a simple question. I say all that just to indicate the quality measures is a challenge, but one of the things we're finding out in our work with FHIR as part of the Da Vinci project is we have now a new tool. It's real time, it's in workflow. It's an opportunity for the provider, when they're seeing the patient, to actually get a real-time response from that payer who knows who that member is, what policy they're in, and what care gaps, right while either the provider or the provider's administrative staff is working on that patient. And also that means, as you heard earlier with the things that the feds are doing, if you've got apps that the members actually have, that means we have a way to actually have the provider, the payer, and the member all be aware of that gap. And also, if that gap's closed, the consumer might be able to tell us, excuse me, that was done. I just did it while I was out of state in another location, so you guys just didn't know, sorry. So there's a lot of interesting things we can do with technology. Look forward to sharing more as the rest of this session goes on.
So my name is Brynn Rhodes. I'm principal and CTO at Dynamic Content Group. So I started, my first exposure to gaps in care was in building a real-time clinical decision support system for a major EHR vendor. One of the first things we did was try to put in place detection of gaps in care for the one of the diabetes control measures, right? So the A1C level is, the A1C threshold is greater than 8 or whatever the threshold is. So instead of trying to build that into every change, as you mentioned, they're changing constantly. So instead of trying to build that in, we separated the technology from the content so that we could keep as the measure changes came through, we could just update the rules that ran in this engine. So that led to my involvement with HL7 and building out specifications to support distributing those kinds of definitions. And ever since then, I've been involved with the decision support and clinical quality information work groups in supporting distributing measure specifications in FHIR and HQMF. So.
Hi, my name is Sharon Kurt, and I'm from Priority Health, and I'm the manager of quality improvement, and one of my responsibilities is HEDIS operations. So I'm the person bugging all the provider organizations for documents of their medical records, which is one of our pain points, is getting access to some of those records, getting remote EMR access whenever possible, which I know can be very disturbing for some or upsetting for some. But we have had great success in getting some of those and getting that data. Now, we were fortunate to use MyHIN as a supplemental data set this year, which was enormously helpful in identifying those measures that were met. So we are really pleased with that performance for this year, and we'll continue that. But gaps in care is, kind of the hot term. Almost every software application that's coming through or being marketed to us provides a gaps in care report. But then if we gave all of those to provider organizations, they would be overwhelmed. Creating a more national gaps in care effort, I think, is really the way to go, because we are really all trying to go after the same thing. We want better care for patients. We want guidelines that all are pretty standard. And so I think I'm really excited about all these initiatives.
Perfect. Thank you, panelists. So we have a few pre-canned questions, but not too many. So start thinking as audience members what you'd like to ask us about. I asked for some tough ones from you guys. The first one we wanted to talk about, so what's the problem statement? How did we get to where we're at? What are some of the factors that caused our current situation where there's so much variance on how we communicate gaps in care and measure results? Does anyone want to jump in? Go ahead, Brynn.
So I think there are at least two factors broadly, right? All the different factors fit into, they're either essential complexity, like they're an inherent part of, it's just a hard problem. We're talking about how do you effectively determine whether or not you're delivering the best care possible. That's a super complex problem, and so there's a whole bunch of essential complexity associated with that problem. And then the other parts are accidental complexity. Things that happened because the solutions to these different problems were being developed in isolation, or because different market pressures or different institutions had different policies, different decisions that have been made. And so I think teasing out the essential complexity from the accidental is really kind of a way to help approach that problem. So that's what I think the factors are.
I think from personal observation, to tag on to Brynn's second point, each organization, whether payer, hospital, physician organization, they all have different priorities at the executive level. Additionally, each organization has different levels of software and different levels of capabilities with the employees, and that creates a playing field that's not level. Although those are points for healthcare, that's not unique to healthcare. Obviously, that's existent across all sorts of sectors. However, I feel in healthcare we have a really good knack at chasing that new carrot in front of us without fixing the problem first. So I wanted to point out, Jim Lee mentioned something yesterday that was really eye-opening to me. Yes, we do need to solve this solution. However, we do know our gaps in care. We have the data. That's not the problem. It's what we do with the data and how that workflow is going to work at the physician offices.
I'll have to add at least one other point to the challenge for the industry is the alphabet soup of everybody who's involved. CMS, ECQMs, NQF, NCQA, the payers, the states. Everybody has a vision of what's a great way to measure quality, but at the end of the day, for the provider burden, the provider abrasion of having to deal with United, Blue Cross, Aetna, the feds, and it's the same health care. Why are you guys all measuring it different ways? So that's a challenge that the industry is aware of. I think CMS has taken some actions to work with NCQA, so there is an effort to align it. I actually also believe FHIR as a common approach, and then Brynn helped write the software CQL, clinical quality language, that provides a common way to refer to the clinical elements, a common way to calculate them, and now we've got the folks at NQF, NCQA, and CMS working off that same base standard, and very painfully aware, because some of you in the room have probably pointed out to them, why are you asking me to measure this diabetes 3 different ways? So there is sensitivity to that, and I think the standards approach that's being undertaken by the industry is also going to help some of that pain go away. Won't go away this year, but again, the future is bright for some approaches to do standards in a quality measures in a standards-based way.
I think that's a great point. And along with everything changing so rapidly, I think the smarter we get, the more complicated we make it. In the past 10 years in my stint in healthcare so far, we've switched from, throw everything at the wall and see what sticks to taking a data-driven approach. And now we're talking so much about social determinants of health and population health. And I think what you're starting to see in geographic regions or different states across the country, the reason that all these different metrics are coming up is because we have more data. We're being more dangerous with it. And we're starting to identify new measures because we know that that's what's going to impact different populations. An example I could think of is our withhold program for the Michigan Medicaid program. We have different goals by region of the state because we've had such great data and we could see what could actually drive change. So the more sophisticated we get, the more complex we continue to make it without really addressing what that overall approach is.
Yes, I agree with all my colleagues here. I do think it is alphabet soup, confusing. And I just recently read a number of grants for different kinds of health centers. And while the requirement of the grant was to cover diabetes and cardiac and COPD, there was no mention by the grant, the organization doing the requirements to have a consistent way of measuring quality. So we've got to start from those kind of efforts, getting national guidelines to use the same terminology. I think that would lend better if the ADA, the American Diabetes Association, could work out in their annual guidelines those measurements clearly that are standard throughout. That might be helpful, and then we could build them in our EHRs and capture them a little bit better.
I'll just throw in there that, remember MACRA said you either are subject to MIPS and the ECQMs that you can pick from there, or you can participate in an alternate payment model, or APM. And there's an ever-increasing amount of APMs being approved left and right, and the only real requirements of being a legitimate APM is that you have risk and quality measures baked into it, right? So we're going to start, and furthermore, those APMs are free to branch out from the standard set of ECQM measures. They're allowed to make their own if it's a specialty kind of organization, what have you. So a lot of accountable care type organizations are coming up with what we would call custom measures that are outside of the specific list of HEDIS measures and ECQM measures. So the amount of measures in our ecosystem is only going to go up. So when we have these results, it would really help to have a standard way to share them, regardless of who wrote the measure. Okay, next one was, what would some of the benefits be of a nationwide implementation of a standard way to communicate gaps in care?
I'll start. Well, part of the challenge for, or the value of having it be nationwide is right now, what we have is vendors that have some unique approaches. The payers are pretty creative at ways to communicate. Some of these opportunities involve working with an HIE or a direct connection for a large payer and a large provider organization. But the challenge is, at least as I've seen it, is the mobility of the population. So we've got snowbirds. They're in Michigan, and then they're down in Florida. So they've got two sets of provider organizations that they're working with. So, geez, I wonder if Florida Blue and Blue Michigan communicate the same way in their care gaps. I bet probably not. And then, of course, we've got the employers. And the employers have different consultants telling them what they think is the good measure for quality. So as a payer, I've got some employers telling me what quality measures they want as part of the contract. And then, of course, the feds and AHRQ are always doing studies and determining what they'd like. So they've got these pressures. And so at least if we had a standards-based approach for communicating those gaps, that would make the provider abrasion easier, and also for the technologies that we're all using. There is cost associated with multiple approaches to do care gaps. Means some consultant's going to get a nice bit of money to help give you your custom approach to care gaps, versus if it's a standard approach, we can take advantage of the amazing strength of the technology and ingenuity tied to a standard, not using that ingenuity just to replicate somebody's unique approach to doing care gaps.
I would add that it's not only snowbird type situations or going to a different state. We are now have that other layer of retail medicine where someone's going to a Minute Clinic or some other clinic or to an urgent care or doing telehealth. Amwell is a perfect example of another method of getting health care. If we could all agree on the gaps, if the patient going to someplace like a Minute Clinic, if Minute Clinic knows they need a BMI and a height and a weight, and they can get it done, that would be really wonderful to feed into a national GAPS database. Whereas it might not show up for a variety of reasons in my claims or in your medical record if you're a provider organization. So I think we need to think big. I think there's so many disruptors in the way we're going to get care and are getting care that the standardization would be very, very helpful.
Yeah, I think instantly we would start to see better outcomes at all levels. One thing from a provider organization perspective, we are graded by the payers on a calendar year performance. Unfortunately, at best, we get GAPS files 3 or 4 months into the year. So we're working on 9 to 10 months worth of data. If we align these and simplify these across the payers, and it's going to be more timely and it's going to be easier for us to share this information with our providers. So what happens is I wait around until March or April and see what the payers, what Tara said is, what they were demanded to change for their quality gaps. So I have to see what the payers did and how they changed their files, how they renamed their measures from last year, write a loader, rewrite the script, and then provide the information to the providers. One of the biggest benefits that we've experienced this year is participation in MyHIN's PPQC program. To have the simplicity of it was such a relief for myself and my counterpart. However, we're still not there yet. Although we have many payers participating in this program, we still have to maintain individual fees with those payers because some are still not calculating them into their HEDIS engines. So we're doing double the work.
I would agree with that. We're one of them. We're still doing double the work, but I think having a centralized national repository would not only be just more efficient, but you'd have more reliable data. Right now, when you have 23 different connections statewide, and you have these specifications, and you have 10 different vendors who are calculating the metrics, it's unreliable. It's open to interpretation. So really, at the end of the day, are we even speaking apples to apples? So I think that's one of the greatest advantages that we would get out of having one.
As a point of clarification, though it's an interesting concept, I was not advocating for one central repository because that's easy to break into and then you get to steal a lot of good stuff, but a standards-based approach so that we can have a federated model where it's easy to move the data because it's always the same consistent format, and regardless of what state it comes from, regardless of what provider, that data can move. It's liquid. That's one of the things that Seema Verma is interested in and why they're pushing for the open APIs, because once we liberate the data and can move it safely, securely with privacy, we can do a lot of interesting things with that data if it's standards-based.
Yeah, I agree with all of that, all the points that have been made. I just want to highlight the number of measures is going up, which is really a reflection of the number of guidelines, the amount of evidence that we have. I mean, it's just constantly increasing. And so we're trying to reduce the amount of time that it takes to get from a body of evidence that establishes a standard of care to reflecting that standard of care in patient care delivery. And one of the things that I think would be the most interesting outcome of a standard representation for a gap in care is the ability to, it will force the conversation of what does it mean if I'm looking at two different results from the same guideline. It will force that conversation, and I think that will drive innovation around how you actually close the gap at the point of care. So.
And just to note, it's been referenced a couple times, but PPQC is the Physician Payer Quality Collaborative, and that's an effort at MyHIN where we brought 12 of the major payers in the state, along with 15 or more of the major POs, all to the same table to talk about HEDIS, how you get supplemental clinical data to the payers, and then also gaps in care on the return trip. And we've made some standards, but they are text-based pipe-delimited files that work for Michigan, but not really scalable to a national level. And what we're really trying to advance is this concept of a national standard, endorsed and created by national companies like HL7 and Vinci and using FHIR to make that more scalable. So, all right. Next one was leading into FHIR a little bit. So we'll let Brynn and Linnell jump on this one first, but interested to hear about FHIR from the perspective of the other organizations. But what is the potential role of FHIR in communicating measure results and gaps in care?
So I think, four kind of things jumped out here, and this isn't exhaustive, just what I'm thinking. First, communication of the data involved. So there are lots of great initiatives happening. There's Argonaut initiatives that are involving vendors and really pushing the coverage of a FHIR-based API and the amount of hospitals and systems and clinics that you can actually reach now with a FHIR API. And so just the ability to represent in a standard way the actual data involved in determining the gap in care. Second, communicating what to do to close the gap. So there are lots of mechanisms within FHIR to support requests like perform this lab or order this or schedule an appointment. So we can describe the actual recommendations that we want to have performed in order to close that gap. And so third is communicating, resources for communicating the actual algorithms for determining the gap in care. There's, in the clinical reasoning module, there's capabilities to define the rule and the behavior that's associated with that determination, so that you can actually have a platform that can consume rules and automatically run them as they're changing from the sources to, again, reduce that development time between evidence and implementation. And then fourth is the timeliness. So, you mentioned, it's 9 months before you're actually even starting. We want to close that. We want this as near real time as possible so that decision support systems are at the point of care actively working to identify and close these gaps. And there's an initiative going on right now, clinical practice guidelines in FHIR. It's an implementation guide that we're putting together to address exactly these kinds of problems at the point of care. How do you describe the recommendation based on a clinical practice guideline in a way that is easy for systems to implement and deliver into healthcare? So,
the thing I'll add is just the story of why FHIR is something that we can move fast. My boss keeps telling me, be careful of using the word fast. Everybody familiar with the Apple Toolkit? Everybody heard about that story? And everybody's familiar with the term viral, the internet. Things happen in overnight, something, an overnight success or an overnight meme that moves around. A reminder with the Apple Toolkit, that was a year ago. I believe 9 health systems signed on early, did that pilot. Within a year, it was 60 health systems and well over 1,000 hospitals. That was the power of using API technology. That's something that started small, within a year had spread throughout the entire country. And FHIR offers that promise. Now again, is something going to move that fast when you've got the health systems and the providers and the payers having to do all the infrastructure that we do for a system? No, it's not going to move that fast, but relative to what? For those of us that are familiar with our pipe delimited systems and our custom systems, 2 years or 5 years is not an unexpected start to finish to get new technology in. Well, now we're talking about a technology that can literally move across the country. It has done that in a year. And so the promise of FHIR is not tomorrow, but once all of the primary EMR vendors have implemented basic FHIR and made that available, release 4 of FHIR, that means all of the infrastructures, whether it's quality measures or whether it's exchanging clinical data or payers being able to get information to the providers at point of care for a patient in emergency situation with that information, which was done in Katrina, mind you. When Katrina happened, one of the payers actually made sure all the EMRs could call them and give the name of that patient and get that information. But that was done by fax machines and phone calls. Imagine that capability with real-time APIs on your phone, on your portals, and engage. So that's the promise of FHIR. And again, as I mentioned earlier, quality was one of the first areas we all thought of, and it's one of the areas we're having, at Vinci, having some of our initial success in working with Cerner, Epic, Allscripts. All the major EMR vendors and all the major payers are active in this initiative, and that's, I believe, going to be a great opportunity to see change come quicker than we've ever imagined.
So there's been a little friendly debate in some of these conversations Linnell and I and others have attended around the country. It's acknowledged that the need for a standard way to represent measure results is accepted, but how do you do that, right? On one hand, we have some implementations around the country that are using CCDAs and continuity of care documents to insert gaps information into those. The advantages being they're kind of already flowing and so on. So I was wondering, I know we're kind of team fire on the stage right now, but could you set up the best argument for some of the debate, or tell us about the debate between CCDA versus fire and their usefulness in terms of communicating gaps in care?
So I mean, to me, the question is whether the representation has been established for what we actually want to communicate in a gap in care. I think that's the more important point to establish. Whether you're using CCDA or FHIR is you can kind of look at that as a serialization format. That's just how you move that information across the wire. And if you have existing infrastructure that is capable of consuming CCDA, if you have a well-established conceptual representation of the gap in care, then you should be able to use that CCDA in those environments. Now, having said that, FHIR can and does exist in heterogeneous environments. It needs to be able to deal with the fact that these systems exist and have a lot of investment and existing infrastructure in place. And so FHIR is about making sure that we can interoperate in that environment and making sure that there's a way to exchange data reliably and securely within that framework. So I don't think they're mutually exclusive. I think you could make an argument that whatever technology makes the most sense for your implementation is what you should go with.
And I've got a English translation for that.
I apologize.
That gets into literally one of the challenges was, I was one of the folks that was, wow, we're going to do this with FHIR. And Diameter Health, we had a very interesting, aggressive discussion about, well, what about CDA? And the answer came out that HL7 has an examples task force. And they give examples of CDA so that the many vendors and many users can see what it should look like. And one of the things I didn't realize was that the examples task force had actually approved a specific way to build CDA so that it could payload a gap. And that's what Diameter Health is testing at HSX in Philadelphia right now. And what's nice is because CDA, many vendors are familiar with it, many of the EMR vendors are familiar with it, they just need an example of how I would use CDA to exchange it, and then you just have to make sure all your trading partners understand, I'm going to do it this way, the example is up on the HL7 website, when you receive it, here's how you render it. Now, since I'm not the most trusting person, I just walked over to the Cerner, Epic, and people and said, excuse me, if they build this, is it going to work? And they said, oh yeah, it's a CDA. We can render it so it's readable by a human. We don't actually have to have the computer understand what's in there. I'll just show it on a screen. Basically, we turned CDA into a fax machine that would move right on your screen on demand, and it's available now by just downloading and making sure your trading partners understand this is the way I build it, this is the way I'll send it, my hen or an HIE can move it around, and that's an immediate thing that can be done. FHIR's a little more fun because when I do it in FHIR, I can put it into your system, in your workflow, on the screen. But in the interim, we really do have care gaps that we'd like to close now, and we have technology we can use now. So it's exciting that we can work with what's coming, but we can work with what we have right now with CDA. That was the English translation.
I'm a big supporter of continuity care documents. However, they present a double-edged sword. So, one of my takeaways personally from this event is interoperability, and we in life and here we have the opportunity to learn from history. So what this event centered around is learning from the mistakes that we made during the meaningful use period. We're trying to fix those so we can become interoperable. That's a vendor issue, but when it comes to using CCDAs to try to extract data in an automatic fashion, that is a people problem. We have staff that switch so often from one practice to the next, and everyone documents differently. And some people don't put the A1Cs in the correct location. So if we're relying on just pulling a query without having that quality checks and balances, we could be missing out on critical information as part of the medical record. So I am very excited with the CCDAs. I'm excited to see how it evolves. But we have to get down to, once the vendors are capable of doing this, making sure that we're training the end users to do so properly.
Yeah, and I'll tag on to that I think one thing that may have been lost in translation is that if the intent was just to use a CCDA as a fax machine, then I don't think that does provide as much benefit as the FHIR representation would. That's one of the really important points, is that FHIR is providing us a way to discreetly represent that information in a way that systems can understand, so that it's not a people problem, so that the fact that, you know, the A1C was entered in the wrong place doesn't happen. I think that's a really important point. If the CCDA is just a different serialization format for that same information, that's great, fine. But if it means that if we define working as it can display on the screen, I think that might undermine what we're trying to accomplish.
Perfect. So I want to leave plenty of time for audience questions, so we'll just do quick responses on this last one, and we'll zoom out a little bit. We were in the technical weeds, but I just wanted to give a sense of what the national conversations are. Once we move beyond understanding the need for a gaps in care standard, what are some of the conversations on the technical side? So thanks for bearing with that. So the last question is about patient engagement, and that came up earlier as well as throughout the conference. But you know, currently quality measures are focused on evaluating providers and plans. Do patients themselves have a role with gaps in care? Should patients be allowed to see if they are considered a gap in care?
I think patient engagement is huge. I would be an advocate for, yes, they should know, but I think the messaging is different. I'm not going to deliver a file, team fire, but I think that we have a huge responsibility to educate people. And what it means to be in gap of care is essentially, what are some basic preventive services that you should be completing for yourself, your spouse, your children. So I think holding that conversation and really getting people engaged in healthcare, potentially removing some stigma, as we discussed yesterday, I think that's our job. And I think that that's really exciting work, and that's a big reason that we're all here.
I do believe that we should get the patients involved. I'll give you examples. So, you know, I need to get my mammogram every year, right? I can never remember what month it is, right? Because it kind of slides every month, and you can't get it too soon, or, you know, the payer, which is me, won't pay for it, right? So I end up relying on that letter that I hope comes eventually and make the appointment. Now, sure, you know, I had a lot of my stuff in Microsoft Health Vault, which is now going away. I belong to like 6 different patient portals. So which one do I look for, and which one do I feed? So that's another issue is, you know, if you're getting care at many different places, you have a portal for everything. And where do I look? So I think, like the CMS interoperability proposal, we need to figure out a standardized way to do that as well, so that I can look and say, oh, I'm due for that mammogram. I happen to have parents that are very disciplined about getting their care every year, and they get their colonoscopy, and they get this, and they get that. And sometimes we don't talk enough about those people who are disciplined to do that, and we spend a lot of time on our unengaged patients, which are, for a lot of reasons, social determinants, whatever, can be an issue. But I think we need to remember that there is a whole group of people that could really benefit from knowing what's next, from knowing what they need to have done, or even understanding what they need to have done, because right now we rely on the provider to tell us what the next step is. If I'm pre-diabetic, maybe I should at least have that hemoglobin A1C once a year, just to, you know, keep monitoring it, and maybe that should be on the list. So I'm a big proponent of engagement and getting people active in their own care, because We need to provide them that data, and we need to be able to support that.
Yeah, I think this is a great idea. So a phrase I heard many times this week is thinking outside of the box. So, you know, like I said, I believe in changing the status quo and not doing the same things that we've been doing year after year. So with that, I think what we have to look at is engaging the patient. They are the consumer, and the consumers can drive business models. And we have a couple layers there. The first layer are the individuals that I mentioned we have to be sympathetic towards that aren't techie and are intimidated. However, what's encouraging is you're able to use your iPhone, you're able to use your Apple Watch and your laptop relatively easily. It's because it's simple and user-friendly. That's what we would have to focus on for the patients. And the next layer that I want to address is every year we get a younger generation of individuals entering the workforce, leaving pediatric care, entering primary care. And every single year, those individuals are starting families, and they're going to want this information at their fingertips, not only for themselves, but also for their children. So from a business perspective, if we want to engage the younger generation, we're gonna have to find simpler, more attractive ways to share information with them. And paper is not the answer.
All right. I think we'll open it up to questions from the audience now. We have just under 10 minutes, so you can just raise your hand and a mic will come to you. This can be about the quality measure space, specifically gaps in care, what those conversations have been, or anything relevant. Dr. Simmer.
Thank you. This question is mostly for Danny, but anyone can answer. I thought I heard you say we've got the data, the challenge is getting the clinical workflow. And I would just like you to expound on what are the barriers in the clinical workforce flow area that make it difficult there. I always thought they never had the data to work with, but my assumption was that you have medical assistants operating under protocols of authority to order anything that's not been done, and that they look at the data before the patient's seen and make sure all the patients are up to date. Why is that workflow the problem?
Yeah, so this was a relatively new concept to me in my first meeting with the MyHand all-payer supplemental data feed. They went around the table and they asked, how many of you physician organizations have one gaps in care report that you provide to your physicians? I was surprised. Out of the 15 or so, maybe 3 or 4 had that information. Regardless, the groups that do, we find a way to deliver that to the practice. However, the practice has to recognize, they have to make the decision as to whether they use our information, or as Bo mentioned, they tackle their ECQMs or tackle their social determinants of health. What is the priority at their level? So I think what we need to do as we provide this information, we need to give them the why are we doing this. So often we're stuck in the world of just looking for results. The results are going to come, especially with fire. We are going to reach that tipping point, but we have to get down to the why at the practice level, and we have to say this is not one more thing for you to do. We're simplifying something and giving you information in a different manner, hopefully to ease your workflow down the road.
I will share a little story. So not in this state, but I worked with a practice of 9 clinics, and we implemented a really, I thought it was really nice diabetic guideline to about 80 providers. We got all the providers on board, and it was very simple. It was very clear. Most of them were, operating that way anyways, and it failed because we failed to work it into the workflow of the office. And so we needed to really make sure that the MAs and the RNs and the office staff knew what their role was and what they needed to do, and we needed them to stop doing the things that didn't make sense. And I think that's a part of the workflow as well. They're overwhelmed already with all the different things they have to do. You have to really look at fundamentally looking at what they're doing and how you can shoehorn one more thing in.
Actually, I only have one comment to make. Secretary Verma talks patience over paperwork. I'm very concerned that we are now talking about information technology over patience. And everything these past few days that I've listened to is making it very clear to me as a consumer that my costs are going to go up secondary to the amount of time and effort that's going into information technology, and we're beginning to lose the human touch. Social determinants, that's a human touch. I can't close a gap unless I ask, do you have a car? Can you get here? Is your neighborhood safe? Do you have the money to afford that? How are you making those changes to stratify risk so that those patients that can't close the gaps in care are adequately cared for?
Part of my response would be, you're right, that's the right question to have. I spent 5 years involved in health equity, was the co-chair of the Social Determinants of Health Committee for the Great Lakes region, and worked with the HHS Office of Minority Health. You're right, those are things to collect, but guess what? If we don't collect the data in an interoperable way and make sure the EMR vendors can capture it so that it can be moved, that human touch that captured the data will get lost, and it'll have to be asked again and again and again because there's no institutional memory, because the EMR hasn't got a place to put it. We've got a Z code to bill it, but we're not talking about billing. We want this to happen at point of care. We want the technology to remember and be able to do those alerts. I would make the case we are making the investment in the technology because we've got a new technology that can go to your smartphone. And if it can get to your smartphone, if you're a payer or a provider, that means I can get it to the member's smartphone. And now I can close the loop like we've never closed it before. That's what Seema Verma's concerned about, that we have the technology, but she used the lever she had to make sure that the payers who are involved in Medicare Advantage and QHPs, we have to follow that drum. And then for CMS, for ONC, the lever they have is for EMRs to get certified, you need to do FHIR. The reason they're doing FHIR is because FHIR is the technology of the future and of the internet and of the consumers. So the only way the consumers can get that technology is if many of us in the room invest the time to make sure that technology is working in workflow. And then I promise you, in 5 years, your consumers will be over the moon with all the great things they can do, but it won't happen until we make the investment now in getting this technology and taking full advantage of it. Is it going to be easy? No, but what's the alternative? People are dying every day with the opioid events. People are dying from mismatched identities, so wrong, in essence, going in for elective surgery and doing surgery on the wrong arm because I got the wrong MMI match. That's crazy. So we've got to invest in the technology to get to the people.
And I'll add just a little bit to that. I mean, one of the things that we're trying to do is make sure that we have a mechanism for the programs and the institutions that are producing the guidelines to be able to distribute those in a way that can be easily incorporated into the system. And being able to answer social determinants of health doesn't matter until you can talk about it in an interoperable way. And once you can talk about it in that interoperable way, then you can put it into your programs and into your systems. So there's awareness generally of that problem, but you've got to get substrate in place to be able to address it.
I think we do have to be careful that we don't replicate what happened with meaningful use at the physician level and having multiple vendors and multiple portals and multiple areas for us to gather our information. So I think we all agree we need the consumers and the patients to receive this information, but I would hope that there's some regulations in terms of the amount of vendors and some requirements that they have to meet. So as you said, so you're not logging into 6 portals at a time.
I will say, I agree. I'm a nurse, so high touch is really important. But 5 years ago, when I looked at gaps in care, it was a very you know, was a list, everybody who didn't have colorectal screening. And now we're adding some social determinants. You know, this group maybe lives in this zip code that perhaps they have less transportation. And now we're getting more data so that we can develop some, what I would call personas of people who have social determinants. And without data, we're not able to drill that down. We can use the geographical information, you know, services and some of the other data to apply to it so that we can figure out what they need, and they don't have to tell us sometimes.
We have time for one more quick one.
I had a situation once where it was very recent, where my colonoscopy and mammogram were over a year old, my prescription. And I called and they told me I had to go back to my provider. Now, I don't know who makes that rule, but my guess is there isn't a lot of insurance fraud with colonoscopies and mammograms. So, but there are a lot of gaps in care with both of those. So, and that's what I said to them, you know, I'm sure there's not a lot of insurance fraud with that. So, like, what happens? I'm a nurse, so I called my provider, but, you know, I had to call them, I had to go through all this. And actually, I was calling her because I'd gotten a little text from her that I was dinging her, okay, on her gap in care, but I was way past. So, like, how can we stop some of that? It just seems crazy that I had to go through all that again to get another prescription for a mammogram and a colonoscopy that I didn't want to get in the first place.
Yeah, and I'm not positive about Michigan, but I know that in other states you can do self-referral for mammograms. You don't need an order.
Oh, no, not here.
So that is one solution, is to make some of these screenings a self-referral type of situation. Then you don't need that. A lot of times it is the provider that's you know, the GI doctor or the hospital's rules that something can only be, you know, a year is too long or whatever. So I agree, that is a bigger hassle. We need to reduce some of those hassles so that people get, and you're right, no insurance fraud with colonoscopy. Yeah. We'd like to see more people get colonoscopies, so.
All right, well, thank you very much. Please help me thank our panel for a great discussion.